Sir, we can't hear you. Dr. Mohit Sharma, we can't hear you. No, we can't hear you still. You're on mute. I mean, you're not on mute, but we can't hear you.
He's not connected to your audio.
Okay, now he has, right. So you're on mute, yeah.
No,
No.
we can't hear you. He's not connected to your audio.
Am I audible?
Yes, you're on.
Okay.
Please call to
Fine.
order.
Thank you for inviting me.
Good evening, everyone. In the absence of Secretary Rotarian Patul Agarwal, I am conducting today's meeting. Today, our topic is, I request President Rotarian Lal Goyal to confirm the minutes of the previous meeting.
The minutes of the previous meeting was circulated among the members, and as we have not received any objection or observation, I presume that everyone has confirmed. So I hereby confirm the minutes of the previous meeting.
Thank you. Today, our topic is hand transplant, a marvel in lifestyle, and our guest speaker is Professor Dr. Mohit Sharma. I request Rotarian Ritika to please give the introduction of our guest. Thank you.
Thank you very much, Rotarian Ruby. And I feel extremely privileged and honored to be introducing our special guest for the evening, our speaker for the evening. So Professor Dr. Mohit Sharma is an MBBS, MS General Surgery, and an MCH Plastic and Reconstructive Surgery, Hand Surgery Fellowship and Burns Fellowship. He's the head and professor at Amrita Hospital, Faridabad. Professor Dr. Mohit Sharma is a distinguished plastic and reconstructive surgeon specializing in advanced microvascular techniques for complex reconstructive challenges. With over 2 decades of clinical excellence, he has established himself as a pioneer in reconstructive surgery and transplantation medicine. Professor D. Sharma completed his specialization in plastic and reconstructive surgery from Safdarjung Hospital, New Delhi in 2002. For the past 20 years, he has served as a senior consultant at Amrita Hospital, Kochi, where he has built a world-renowned practice in reconstructive surgery. In 2015, Dr. Sharma and his team launched India's first vascularized composite allotransplantation VCA program, marking a historic milestone in Indian medicine. Under his leadership, the program has developed as one of the world's largest single-center experiences in hand transplantation, positioning Amrita Hospital as a global leader in this highly specialized field. Professor Dr. Sharma enhanced his expertise through clinical fellowships in burns and hand surgery at St. Andrew's Centre for Plastic Surgery in the UK, the nation's largest burns unit and one of its premier reconstructive surgery centres. He has also trained extensively with internationally recognized leaders in reconstructive plastic surgery, continuously expanding his knowledge and surgical techniques. As a respected voice in the medical community, Dr. Sharma serves as a reviewer for multiple international journals and Indian Journal of Plastic Surgery. His peer review work helps maintain the highest standards of research and clinical practice in this field. Driven by his commitment to advancing surgical education, Professor Dr. Sharma is passionate about creating high-quality educational videos in reconstructive surgery. These resources serve as valuable training tools for the next generation of reconstructive surgeons, extending his impact beyond direct patient care to global medical education. Professor Dr. Sharma's practice encompasses the full spectrum of reconstructive surgery with particular expertise in complex microvascular reconstruction, hand and upper extremity surgery, burn reconstruction, vascularized composite allotransplantation, advanced plastic and reconstructive procedures. With this illustrious career, we are just in awe with your profile, sir, and we are looking forward to hear from you everything that you have to share with us today.
Thank you very much, Ms. Ritika. I think this is too much of a big introduction. Thank you once again. Without wasting time, if you permit, should I start the presentation?
One moment, I will just make you the co-hosts, please.
Should I share the screen?
Yeah, please share the screen.
Can you see my screen?
Yes, please.
Yeah, just a minute. You can see?
Yes, please.
Okay. So, thank you once again. So I'll start, as Madam mentioned, that our program has become the largest single center program in the world on upper extremity transplantation. And this is, yeah. So we started our journey from Amrita Institute in Cochin in 2015 regarding transplantation. And now we have started doing transplantation at Delhi, NCR, Faridabad, Amrita Hospital as well, which is shown here. And till now, we have done 35 upper extremity transplantations in 19 patients. So it's a huge number because worldwide there have not much has been done in this field. Around 200 transplants have been done worldwide. So this is a graphic representation of the level of transplantations and the demographics of the patients that we have done. So the hand amputation scenario in India is almost 25,000 amputees are added every year. And there's a main etiology remains the high tension electric wires. And this is because we feel, because of the poor urban planning, that the houses are allowed to be constructed near high tension lines, or high tension lines pass near the houses, and which is creating havoc. And there's the largest subset of people that we get for transplantation is the electrical burns. Also, there are farm and industrial injuries and accidents. So when a person loses hand, he becomes totally incapacitated. This video is not running. Sorry, just a minute. So basically, depends on others for daily living, occupation, self-care, and social life is totally disrupted. And then one alternative is there, the prosthetic hands. So prosthetic hands, they lack sensation, lack fine motor function, require repeated maintenance. And in our daily life, there is a big use of water in everyday activity, and you cannot use these hands in water. So that remains a severe limitation. Also, the economic effect is there. There's a loss of revenue. There's a big cost of rehabilitation, and the family support is the backbone of the patient care in these amputees. So there's a big need for this procedure. So as I said, the options available are either we do prosthetic rehabilitation, or which is mostly done by mechanical or myoelectric hands, or we do upper extremity transplantation. I start with, these are our first patients that we did in 2015. The first one was done in January, and the second one was done in April. The first patient is an Indian management employee, and the second was a BSF, the Afghan Security Force captain. So this is how it is done. We identify a brain dead donor and do the blood matching, and for that, a lot of matching is done with the blood group as well as the lymphocyte cross match. And when everything is okay, there are 4 teams are formed, and 2 teams prepare the hands of the recipient, and 2 teams are responsible for retrieving the hand. So we mark the veins on the hand, and then we prepare each and every structure and tag every structure, and also simultaneously the other teams retrieve the hand at the requisite level, whatever the level that we deemed fit for that level of transplantation. And that stump is closed, and the body is fitted with the prosthetic hand so that for the family, the body is not mutilated. So this is the most important part. When we popularize the availability of this technique and this availability of this surgery in the country, the most important emphasis is to be given to the family that the body will not be mutilated. Yeah. The hands can be donated like other organs, and once the hands are donated, the patient's body will not look mutilated because we will apply the prosthetic hands on the patient. And then the hand is brought and over an ice pack, it is kept, and then we prepare every structure and do the tagging and plating. And the orthopedic surgeons unite the bones and do the osteosynthesis. And then we do one of the anastomosis of artery and veins and start the circulation. And then it becomes quite messy, and you can understand that we have to join each structure. So both the hand, the recipient side as well as the donor side, we just match everything and tag everything so that it is not confusing that. And then we do the checking of the hand, and finally we check the tension of the tendon repair, and then do the nerve anastomosis and then close. So this is how it looks. And our first patient, the first thing that he wrote, he thanked the donor. So the first donor, he was showing his extreme gratitude, and he just thanked him with his name. Yeah. So that and underscores the importance of donation in this field. So this is the kind of function that we get. It's practically a near normal function, and patient returns back to his normal life. But this is almost at 1.5 to 2 years from the time of transplantation, because it takes a long period of recovery and rehabilitation and occupational therapy and physiotherapy. Second gentleman went to Afghanistan, and then he was sending his videos from there, and he got promoted to the rank of major, and he sent these videos of firing the gun. The first patient is working in our Cochin Institute as a patient counselor, and he is married, has 2 children now, and it is almost 11 years after the transplantation. He is leading a normal life. This is the third patient at a slightly higher level, in which we retrieve the hand even at the higher level, at the upper arm level. Then we prepare all the structures and then bring the hand together, and the requisite amount of bone which is present, the same length of bone is discarded, and then we do the osteosynthesis, and the hand looks like this initially, but as the nerves grow, we monitor the growth of nerves and the sensation, and this is the kind of function patient achieves at around 1.5 to 2 years time.
So we are not hearing any volume from the videos that you're playing, just saying because you were adjusting the volume.
We can't hear you, doctor.
Yeah. I'm not speaking.
Okay, then it's fine.
I was just showing the video. That's why.
Okay.
Yeah. So this is the fourth patient that we did, and she is an engineering student, and she lost both the upper limbs in a road accident. The bus driver slept at 4 a.m. and the bus turned over, and her hands got trapped. And then in her, we transplanted the hand of a male, and it was a similar aged boy who tragically died in a road traffic accident. But the family was gracious enough to donate the hands, and then you can see the mismatch between the bones. But she recovered very well, and this was her function at 2 years, and now she has joined one of the big companies after doing her graduation from IIM Kolkata. It is 7 years down the line. So there's a extensive rehabilitation which goes on with these patients. The hands at this level don't start to function immediately. So I'll move forward. She progressed very well, and over a period of time, the color of the hand also naturalizes and starts matching the color of the recipient. Can you hear me?
Yes, we can hear you.
Yeah. And now this is her function at almost 6 years. She can write for more than 3 hours. She has given all her exams on her own without taking any assistance. This is at 7 years. She is doing well. This is our fifth patient. She is a diabetic and 44-year-old woman. And then she is also doing extremely well and is independent in her daily activities. This is our eighth patient from Yemen. And then he has come here in a bomb blast. He lost his both the corneas and injured lower limbs, lost both the upper limbs, and we did the corneal transplantation, our ophthalmologist. So he started seeing it, and this is his testimony to the.
So we can't hear. The volume is not shared. You have to enable the volume sharing from your end.
Just a minute. Sorry, just a minute.
Please.
Just a minute. Let me. How do I enable the volume in this?
So
Yes,
actually, when you
When
share,
you reshare it, and at
Okay,
that time
yes.
when you resharing, there is an option
I
of
just stop sharing. Stop
yeah,
sharing.
first stop sharing, then
Okay.
reshare.
And
Well, you-
there is a audio
share
reaction.
audio,
Audio.
enable audio. There's a button which says
Just a
enable
minute.
audio.
Same as system.
It's somewhere on the right.
Leave test
Bottom.
speaker. Leave computer audio settings. Audio
Yeah.
settings.
When you start sharing, there will be a screen which on the bottom
Okay,
part they will
one
say
second.
enable audio.
Share sound.
Just a
Share
minute.
Share
audio.
sound. Share sound.
Share
It says.
sound.
Multiple.
It's on the right side.
Advanced.
On the very
I
same
know.
page.
Just a minute. Just normally I am able to share the audio, but I'm sorry. This is when I am sharing. Just let me see. When I share,
Yes. On the right hand side, there is a share options, it says.
share
And
sound. Okay,
yes,
share
Yes,
sound.
that's the one.
Oh, sorry. Yeah, share. Now it should be fine. This one, this should be okay. So, just a minute. So this is.
Hello everyone.
You can hear?
Yeah, we
Yes.
can
I
hear
am
you.
Islam Ahmad.
Yes.
I am from Yemen. I came to Amrita Hospital for hand transplant. Then before 2 years, I did the hand transplant. Now my hand is good. I am so happy because of that. Can I drink coffee, tea? Can I rely on myself? Can I do many activities right now? That's why I'm very happy. My life come back to me. I have new life because of Amrita Hospital.
This is one patient. He had such a serious injury on the right side that we could not transplant on the right side. We did transplantation of only one uh, uh, left upper limb at the supracondylar level, and he is living a good life. He's driving in Rajasthan and then running his own taxi with that, and then he's totally independent after transplantation. This is our 14th patient from Kerala, and then you can see his function. He's totally independent now. He has joined his job back in Apollo Tires. So we need for these things a good infrastructure, supportive departments, experienced team, established protocols. We are also trying to train other doctors and establish many other centers like Global Hospital, Mumbai and Chennai. We have helped them in setting up their transplant programs, and even the government institutes like KEM Hospital in Mumbai, the Gangaram Hospital in Delhi. They have also done one transplantation. So we are trying to help other centers like Stanley Hospital in Chennai, and we need better transport facilities for donated hands. We need more awareness regarding availability of transplants and necessity of hand donation. Also, to establish, we did all these things to establish the transplant program in North India. We got the permission, training and liaising with the existing and active transplantation centers in personal air transportation and green corridor arrangement and public awareness. Also, the Neurology and Neurosurgery Association, emergency medicine, trauma unit chiefs, and intensive care unit chiefs have to be made aware about the possibility of donation. So they have to be aware about the possibility that this can be achieved and this can be done in our country much more effectively. And also, we need more transplant coordinators to talk to the patient's family. But of course, they can talk only when the doctors initiate the process. So this was the first transplant in the North India. The gentleman with already a kidney transplantation, so we transplanted his left hand because he was already on immunosuppressive medications. So he's doing well. This is the second patient we did. Is a boy who lost his upper limbs and one lower limb in a train accident in Shahadara while he was crossing the track coming from a school. So we did the bilateral upper extremity transplant, and now at 15 months, he's becoming independent. He's able to eat on his own. He's able to lift lighter weights. This is the third patient that we did on 31st December of 2024. And she's doing PhD in yoga in AIMS Rishikesh. She lost both her upper limbs 11 years ago in a tragic electrical accident. This is her video.
मेरा नाम ट्विंकल है। आज से करीब 12.5 साल पहले मेरे साथ एक एक्सीडेंट हुआ। मुझे करंट लग गया था हाई टेंशन वायर से, जिसकी वजह से मेरे दोनों हाथ मुझे खोने पड़े। इतनी इंजरी ज़्यादा हुई थी कि मेरी जान बचाने के लिए डॉक्टर्स को मेरे दोनों हाथ बहुत ऊपर से हटाने पड़े और पैर भी बहुत बुरी तरह से इंजर्ड हुए थे। लेकिन किसी तरह से बहुत सारी कोशिशें हुई, डॉक्टर्स की लगातार ट्रीटमेंट चला, पैर ठीक हो गए। लेकिन जो हैंड्स हैं वो बचाना बहुत मुश्किल था, तो वो नहीं बच पाए। हाथों के बिना लाइफ बहुत मुश्किल होती है। मेरे लिए बहुत मुश्किल था इस चीज़ को एक्सेप्ट कर पाना कि अब मेरे हैंड्स नहीं हैं। उस समय मैं 25 साल की थी। अब से करीबन 12.5 साल पहले ही हादसा हुआ था। उसके बाद मैंने और मेरी फैमिली ने बहुत स्ट्रगल किया। मेरे ट्रीटमेंट बहुत लंबा चला, तो किसी तरह से मेरी जान तो बच गई, लेकिन मैं किसी काम करने लायक नहीं रही। काम दूसरा तो क्या करना, मैं अपनी केयर खुद करने लायक भी नहीं रही। उस समय मेरा बच्चा सिर्फ 10 महीने का था और मुझे उसकी वजह से अपनी फैमिली से भी अलग होना पड़ा, हॉस्पिटल्स के चक्कर काटने पड़े, बहुत सारा मुश्किल दौर था। लेकिन किसी तरह मैं ज़िंदा बची। होप थी कि शायद आने वाले टाइम में मैं ठीक हो जाऊंगी। उस समय तो मैं चल पाऊंगी ये भी पॉसिबल नहीं था। इनफैक्ट अगर मैं कहूँ कि मेरे बचने की उम्मीद भी बिल्कुल नहीं थी। तो काफ़ी लंबा स्ट्रगल था। उसके बाद में फिर मुझे किसी तरह से अमृता हॉस्पिटल के बारे में पता चला। डॉक्टर मोहित सर से मेरी बात हुई। उन्होंने मुझे बताया कि हैंड ट्रांसप्लांट मेरे केस में टेस्ट करने के बाद पता चलेगा कि पॉसिबल है या नहीं है। और मैं आपको ये बता दूं, जब मेरे हैंड्स गए तो उसके बाद मैं ना तो पानी पी सकती थी, मतलब एक पानी की घूंट पीना भी पॉसिबल नहीं था। पर्सनल ध्यान कैसे रखना है, खाना पीना, ब्रश करना, अपना पर्सनल हाइजीन मेंटेन करना पॉसिबल नहीं था। मेरी फैमिली ने किया, मेरी मम्मी, मेरे हस्बैंड। फिर क्योंकि पूरा टाइम कोई कैसे कर पाता मेरी देखभाल, तो हमें किसी तरह से एक हेल्पर मैनेज करनी पड़ी, जो लेडी हमारे लिए बहुत मुश्किल था उस टाइम पर कि हम हमेशा किसी को अपने लिए रखें। बहुत एक्सपेंसिव भी था, पर हमने मैनेज किया क्योंकि और कोई रास्ता ही नहीं था। तो एक हेल्पर हमेशा मेरे साथ रहती है, वो मुझे खिलाना, पिलाना, ब्रश करना, नहलाना, कपड़े वगैरह पहनाना, सारा काम एक हेल्पर के थ्रू ही होता है। मैं अपने आप कुछ भी नहीं कर पाती। और जैसे हम मोहित सर से मिले तो सर ने एक उम्मीद दी कि शायद ट्रांसप्लांट मेरा हैंड ट्रांसप्लांट पॉसिबल है। कॉम्प्लिकेशंस हैं बहुत ज़्यादा, लेकिन अगर हैंड ट्रांसप्लांट होता है तो शायद मैं फिर से अपनी लाइफ को पुराने तरीके से, मतलब एक तरह से इंडिपेंडेंट हो पाऊँगी। शायद दोबारा से अभी ऑलमोस्ट ज़िंदा नहीं हो, फिर से ज़िंदा हो पाऊँगी, अपनी लाइफ को जी पाऊँगी। तो अगर हैंड ट्रांसप्लांट पॉसिबल है तो वो सिर्फ इसलिए कि अगर कोई अपने हैंड्स डोनेट करने के लिए आफ्टर डेथ या ब्रेन डेथ जो भी कंडीशंस होती हैं, उसके बाद अगर कोई मेरे लिए मैचिंग डोनर मिलता है तो मेरा हैंड ट्रांसप्लांट पॉसिबल है। और हैंड ट्रांसप्लांट के बाद मैं फिर से शायद अपनी ज़िंदगी को जी पाऊँगी।
So we did on 31st December night, we did her upper extremity transplantation almost at the upper arm level. And these are the pictures. It's a very complex surgery. And she's recovering now and improving rapidly. And she, in the follow-up, her muscles have started to slowly function. And the left upper limb is also functioning well. So I think by the end of 1 year, she should be able to do activities of daily living, and then she is able to do the very basic things. Now, at least she is able to scratch her face with her own hands. And this is the final case that we have done. She's an anesthetist and lost her hand in some intraarterial injection. And then we have transplanted her again with a male hand, and she is also recovering. Presently, India has done the highest number of bilateral transplants in the world. Unilateral transplants are, there is a lot of dilemma in unilateral transplants, so we have not done much because it is not considered a very appropriate indication. Only it is considered an indication if it's a dominant hand and the patient is not able to adjust to the life without that hand. So we try to avoid doing that as far as possible. But overall, we have done 72 transplants compared to the worldwide, the data which we have around 182 transplants. So it is, we are reaching nearly 40% of the world's transplant in just last 10 years. This is our team of consultants at Delhi Amrita Hospital, and this is our team at Cochin with Professor Iyer and other consultants. So we work together as one team, and these are our fellows who have been helping us throughout in the transplantation. With that, I finish my talk. Thank you very much.
Thank you very much, Dr. Mohit. Just please close it. Yeah. Yes, thank you very much, Dr. Mohit, for giving your very, very illustrious and very informative presentation. I'm sure all our members and the viewers who are watching this live or who are going to watch afterwards will be benefited with this particular presentation of yours. Before I will open for the questions for our members, I have few things which I would like to ask. You mentioned that in the entire world, India has done so many transplants. Is it because in the developed countries such type of hand accidents are not taking place, or they are not aware as, or they are not that much advanced in hand transplantation, or in like in India?
No, they are very much advanced, but it is the poverty of the developed countries because of which they are not able to afford. According to us, their costs are exorbitant, and their insurance companies are not covering the transplant because it is very costly. So compared to our country, the United States, hand transplant will cost at least 15 times more initially, and in long term, it may cost 50 times more. So it is incredibly costly, and they are not able to afford it. And we are able to do it because our costs are low and our drugs are cheaper here, much cheaper.
Okay, but like UK, they have NHS system. Is it covered under NHS or not?
Yeah, it is covered under NHS, and they are in UK only, they are the most active program other than our programs.
Okay. Now, what is the cost? Can you give some rough idea about the cost of the transplant?
Yeah, in our center, like in private centers, generally it costs around 25 lakhs for a unilateral transplant and for 30 lakhs for bilateral transplant. Okay. Because patient has to stay in ICU for long, and we have to use all kind of extreme aseptic precautions. Also, there is additional cost if the hands are flown by using a chartered flight. Then around 7-8 lakhs more are added because of the chartered flight. And you should have some reserves of 10 lakh more to provide for the drugs in first 2 years, because there may be some complications.
Insurance company or Ayushman Bharat or PMJAY scheme, are they covering this or not? Like in kidney transplant and other heart and lungs transplant, they are covering at least this PMJAY scheme and the Ayushman Bharat up to 15 lakhs.
And, I think it is not covered in Ayushman presently, because Ayushman, especially for the reconstructive surgery, there has to be serious thought given about the rates, because hospital, it is unsustainable for the hospital, and especially for the reconstructive surgery. But For urology and cardiac surgery and other things, there are good packages in Ayushman, and they are more sustainable for the hospitals.
And you
But
have
I think
mentioned,
insurance companies should cover. I think
yeah,
insurance companies should cover. Uh, that's I don't see any problem.
but then the premium they will charge very much. Now you were mentioning about the transportation of the hands. Now, how much time the hands can sustain, like a heart beat, after harvesting 4 to 6 hours? What is the time period for the hand?
See, we have to do it as fast as possible, but there is a ischemia time. One is warm ischemia time. One is cold ischemia time. Like when we take the hand and then we perfuse it with a preservative solution, University of Wisconsin solution, and then it becomes cold and perfused with the solution, and we keep it in a cool box. We have transplanted hands with a cold ischemia time of almost 8 hours also, and it works. But we have to try to minimize the ischemia time because that is directly related to the long-term outcome of chronic rejection. This thing. If it is the ideal situation is if we get from the same hospital or from nearby.
And
It is not very ideal.
what about legs?
Legs only in Spain, one double leg transplantation was done many years ago. And after 2 years, because of the side effect of drugs, patient developed a brain tumor. So the legs were removed. And because the leg prosthesis, the lower limb prosthesis are so good that nobody is doing it in the world.
Okay. Now, my last question to you is, what about the thumb impression and the hand lines?
We have taken the photographs and personally want to do some talk to some palmist and somebody who can give some comments on that, because obviously it becomes the hand, the thumb impression and hand lines become of the donor, but the patient can re-register and
So I mean, for Aadhaar card and others, one has to re-register again with the new thumb impression, etc.
yeah, for the biometrics he can re-register. That's not a problem.
There was a news report that in Pune, the original lines developed. I don't know whether it's a fake news or is it because.
See, we have also taken photographs of the hand and hand lines, but you see, it doesn't matter much because whatever is the there is no conflict because the person who has given the hand is no more in the world. So there are no two people having the same thumb impression. The gentleman and the family who has donated the hand has gone, giving the hand. So the thumb impression will remain unique only, and then he can just re-register it. That's all.
Okay, thank you very much. Now I am opening it for our members. Please unmute yourself so I will see. So I will ask you to ask the question. Just unmute. Yes, Rotary and Himlata ji.
Yeah. Good evening, Dr. Prof. Sharma ji. It was a wonderful presentation. Actually, hand transplantation is indeed a remarkable achievement here in reconstructive surgery, offering hope and significantly improved quality of life for the individuals who have lost a hand. Here, I have one question, sir. What are the major essential considerations surrounding hand transplantation, particularly given that is a lifestyle rather than a life-saving organ donation? Because it is not a life-saving procedure. The distinction raises significant ethical questions also. So I want to know the risk-benefit analysis of this.
See, the main thing is when a person loses both the upper limbs, you just imagine not using both of your limbs for a day, and there won't be any ethical dilemma in your mind thereafter. So ethical dilemma is only for the unilateral hand, because a person is able to do most of the work with single hand also. So they are mostly independent, even with single hand, although it is difficult for them. So there is an ethical dilemma only for unilateral hand. There is no ethical dilemma for bilateral hand if the patient is totally dependent on others for every single thing and he wants to live with dignity. People say when we give them option of prosthetic hands also, although he can work with prosthetic hands also, but that option is always given to them. Those who say, okay, we can try that and we may manage, that's fine, because always they are literally forced to use that.
Okay.
So those people who are totally dependent on others, the higher the level of amputation, the more the dependency. And we are not in a position to argue with them because they are miserable. They say that even if I live 20 years less, I want to live with dignity.
Okay.
What is
Thank
the cost factor? Actually, I feel the cost factor is more, sir. Normal people cannot use it.
See, I tell you.
What is the time factor also, sir? How long it works? I mean, they have to take rest and all those things. It takes
See,
1 year or 2 years.
I'm talking about normal people.
Yeah.
Like if you
They
could
can't even
define
imagine,
normal,
no, sir. That's what I'm asking.
if you could define normal people for me,
Okay.
like
No,
what do
normal
you
people
consider?
means, I mean, they're not, I mean, the poorest weaker section, I'm telling you. Weaker section.
Yeah.
Like they're, I
So
mean, then they're just falling down from the top ceiling like that and losing the hands. And
yeah.
the
So I tell you
dependency
one
level will
thing.
be more on them.
Yeah,
But
just listen the
yeah.
answer, please.
Yeah.
You are right. The thing is, the patient, that young boy that we did from Shahadra, his father is a auto driver. Okay. They went through Milab Foundation, and in 1 month they collected 35 lakhs. There are a lot of good people like you who can facilitate donation. If everybody in a city donates 100 rupees also, in 1 day you get, and there are a lot of good people who want to help others. So it is about networking. If like good people like you come forward and put their might behind these people, then it takes only 15 days to collect the money. There is one more patient. Uh, she was a teacher, and both husband and wife got burned, and she lost both the hands. And they were in a situation that neither we are too poor nor too rich, but not in a position to collect 35 lakhs for hand transplantation. Again, I suggested them go through some foundation. And now, in 1.5 months, they have collected 38 lakhs. So, see, there are a lot of good people around who want to contribute only if they know that the money is going in the right hands. So, till now, lot of poor people have been done. Most of them are lower middle class only who have received the transplantation. The rich are lesser.
Okay. Thank you very much, Rotarian Himlata ji. Rotarian Dr. Raman Goyal, please.
Yeah, good evening, Dr. Sharma. An amazing presentation. You know, I'm a bariatric surgeon in Mumbai, and you know, good to see your outcomes and how this is helping people. What I wanted to know was how difficult it is to support these people psychologically. I mean, they, as you are showing, some of them are just moving their hands after 2 years. That phase, initial 1.5 to 2 years, it must be so frustrating for them. Or, I mean, do you have psychologists supporting them? How do you manage this? It seems so difficult for me to keep their morals high. They have gone through pain and money, they spend money. And after that also, if they don't see much outcome on a day-to-day basis, so how do they survive?
Yeah. See, if the transplant is done at the distal level, the movement is immediate because the tendons are there. So they are immediately able to move the hands, and within 6 months, they get most of the function. As we go higher, it is not that suddenly after 2 years function comes and then for 2 years they are doing nothing. It's not like that. It gradually improves. So for the proximal forearm level, they start getting finger movements at 100 days. And then it improves. So that gives them a good kick. Oh, that it is moving. And then that keeps them engaged. The higher we go, like if we come to the upper arm level, as I showed you, this lady, we did on 31st December. Now it is 4.5 months, but her biceps muscle is contracting and then she is able to control the elbow. That's a big thing for her because first time in her last 12 years, she is able to bring the hand to her face and able to scratch. She was not able to do it. So that keeps them going. Slowly it keeps on improving and then they become better and better. It is not that suddenly they get movement after 2 years. They get sensation, they get more control, and there is a kind of a excitement in their life that, oh, slowly it is improving.
And we saw some wonderful results, but what is the kind of downside do we discuss with these patients? What is the possibility that the transplanted hand will not work?
Yeah. So we discuss everything. 1% chance of malignancy because of the tacrolimus and mycophenolate that they are taking. They can get post-transplant lymphoproliferative disease. 2 of our patients have got that. There can be death because of sepsis. One of our patient has died on 7th post-operative day. Then there is a risk of chronic rejection, that even if the hands are functioning at 2 years. See, one patient, the third patient, which I showed you with extremely good outcome.
Yeah.
He went to a church and the pastor told him that Jesus Christ will take care. You stop the medicines. And he stopped the medicines for 3 months without telling us. We arranged all the money for him. And then after 3 months when he started, his hands were already fibrosed when he came to us. And finally, 6 years down the line, we had to remove those hands. So that downside is always there. If somebody does not understand, we try to select our patients extremely well, try to motivate them. But anything can go wrong in these patients. And we discuss everything. That if you don't take medicines, you are going to lose the hand. Even if you take the medicines, then there is a possibility of chronic rejection. Then also you may lose the hand. There is a risk of kidney damage because of tacrolimus. So you have to keep on. It's a responsibility for life. We have to just manage them throughout life. But those who are sincere,
yeah,
they do very well.
So let's say 90% success rate in. I mean, what you are saying is a very small percentage, isn't it? 1 or 2 or 5%. 90 to 95% patients will have a good enough function.
See, worldwide, if 200 transplants are done, and we have done 72 in India.
Yeah.
And the whole experience it started from 1998. The French guy was done. And then he was a criminal. So in 6 months, he stopped taking medicines. So he lost his hand. But the longest one, 1999 in Louisville in USA, they did. That is doing well till now. So it varies. Somebody may do extremely well. Somebody may get chronic rejection. The overall experience is of worldwide. You imagine if 200 patient experience is not a big experience.
Right.
So we are evolving, but some patients, like out of 19 patients, 11 of our patients have returned back to work and they are working. So that is a significant thing, very significant thing.
Okay, last comment from my side. You discussed about the insurance thing. Dr. Soumya, who is a reconstructive surgeon in Tata Memorial, she's working very hard. We had a detailed discussion with her just few days back for the insurance coverage for reconstructive surgery. So maybe you can connect with her, or I can put her to you, and join the efforts to get the insurance people to realize how important these surgeries are. Great job, Dr. Sharma. Thank you so much for showing this to us.
I know Dr. Soumya very well. She's a close friend, and I know all of them. The only thing is, now when we are taking insurance of 1 crore, this 25 lakhs should not be a problem, because insurance companies are regularly covering even 50 lakhs for some complex thing. So if somebody is insured, it should not be a problem. Now everybody is taking a top-up plan or this plan, which will go up till 1 crore or 20 lakhs. At least whatever they are covering, 15, 20 lakhs, they can give, and rest patient can arrange. So most of the patients in future will be able to afford it. And those who are not able to afford, there are a lot of generous people like you who can help them with putting them through some foundation, and people giving even 1,000, 5,000 rupees, they can just make up for the remaining money in no time.
That's right. That's right.
Okay. Thank you very much, Dr. and Dr. Ramesh. Dr. Mohit Sharma, you were saying that you have done a total about 72 in India we have done. Now, last year only about 1,000 brain dead people donated their organs. There is a dilemma or some hitch to donate hands? Because people are donating kidney, lungs, or heart, liver, but what about the hands? Are we not getting it, or the wait list is not there like in other or for the other organs?
The main reason is awareness among doctors and their desire to ask for it, because most of the centers in which donations are happening, the plastic surgeons are not doing the transplant. So people are not bothered to ask. That if they ask and the hand will go somewhere else, and the awareness among the doctors is also very low about the possibility of hand transplantation. So if the critical care specialist, neurosurgeon, and the people there who are declaring the patient brain dead, at least they have to initiate it that, okay, this is also a possibility, because people are very generous. If they are given a chance, they will donate. I have realized that people are so generous that they want to help others even when they are dying, and our experience is incredibly good. Most of the people who are asked, the families also go all out in the consideration. Only in some cases there are refusals.
This
But
Noto is maintaining the Noto and Soto are maintaining the wait list for a hand transplant also.
yes,
So it is monitored by them, not by
yeah.
Okay.
No. It is totally monitored, and Noto only gives us a call that there is availability of hand, and then they ask in sequence. Now there are 7-8 centers, so they ask based on the region and based on the priority and the preference they ask.
Okay, so thank you very much. Anyone else who wants to just unmute yourself, who wants to ask the question? Yes, Rotary Nitin Gupta, you'd like to ask a question? Please unmute. Please unmute. Dr. Nitin Gupta is from USA, and he's a kidney recipient himself. Please unmute. I think no, it's not getting it unmute. Dr. Nitin Gupta, no.
Mute.
Yeah, yes. Now it's
Okay.
Yeah, you can ask the question.
Yeah, so there's a hand transplant you did for the person from outside the country also, right? So how was that managed, and what was the criteria for that?
See, the rule is that at that particular point of time, in the list, if there is no Indian patient waiting, then you can do to a foreigner also. But if there is any Indian patient registered in the waiting list, he gets the first preference. So what happens, suppose if we have an Indian patient waiting and a foreigner also waiting, and the blood group is not matching with the Indian, then we can do to a foreign national also.
Mm-hmm.
But the first priority goes to Indian if it is.
Okay, thank you.
Thank you very much, Rotary Gupta. Yes, Professor Dr. Sudhisan, Rotarian Professor Dr. Sudhisan, your question, please.
Thank you, Dr. Sharma. It was a very, very impressive presentation. I got to learn so many important things about limb transplantation. What was your motivation to get into this new field, and what kind of serious challenges do you face today?
See, we were doing very good reconstructive surgery in 2010-11 itself, and then we were thinking that for these amputees, obviously we were going through literature and we knew that the transplantation is happening, and it is impossible to go and watch somebody doing a transplant because it happens very sporadically. So we were just thinking that there are so many patients here in our country, why should we start it ourselves? So we just read all the literature and then planned it and made a team and took permissions and then just did it. Actually, for the first 2 transplant, we did not even do any cadaveric dissection. But thereafter, for the upper level transplants, we did a lot of cadaveric practices also, because we have done at all levels, from wrist, proximal forearm, supracondylar, mid-arm, upper arm, and shoulder level also. So everything requires a different technique, and we were doing a lot of practice sessions on cadavers in our dissection halls. And we developed the whole program on our own. We didn't go anywhere for that.
Okay, thank you very much.
Commendable, very commendable. Thank
Thank
you.
you very much, Rotarian Professor Dr. Sudhi sir. Dr. Mohit Sharma, as you are saying that you have done it on your own, in your MCH, is there any specific chapter or this thing was told you or taught you about this particular field, or is nothing like that? It's a general MCH for reconstructive surgery.
See, I was doing MCH in year 2000 to 2002 in Safdarjung. And the first working hand transplant happened only in 1999. So there was nothing much at that time. But only later, when we were reading journals and literature, we were aware that this is happening around the world. And mostly in USA and France, it was happening. So we just also thought we'll also do it. Now, in a very short time, our numbers are much, much bigger than anybody else's number. And it is bound to explode only because a lot of other centers are coming up.
So this MCH nowadays, are they giving a specialized chapter or teaching in about this particular surgery?
Yeah. There are big chapters and a lot of people, the awareness level is more, and even the textbooks have big chapters. And even we have written chapters in the textbooks about this transplantation.
And about the burn, you have mentioned that you have taken the training in UK. How much duration was the training period that?
See, I was just doing one fellowship in burn surgery and hand surgery for one year. So total 2 years I was there. Although I had a permanent registration to work there, but I obviously for love of my country, I just wanted to be here only.
No, why I am asking this question, because one of our member, although he was there, but now there is a poor connection. He's from USA. He said that for skin retrieval, he has done a course for 4 years, and then only they are allowed to retrieve the skin in USA. While in India, there is a course for the technician is about 2 weeks, and for the doctors also about a week or 2 weeks in Mumbai.
Yeah.
Do you think that we should also have this similar types of courses in India, specialized courses, so that the proper, with a full dignity and with full medically, the retrieval of this skin or whatsoever we are doing can be done?
See, just because somebody is taking 4 years, it doesn't mean that he is doing it with more dignity and doing it better. Indians are quick learners, and there is absolutely no need to apply that US or UK criteria on ourselves. So we do it fast and we do it better, and there is no need to waste 4 years of life in retrieving skin. We can teach people doing it with extreme care and dignity in 1 hour.
Okay.
There is no problem. Even 2 weeks is more.
Okay, thank you very much. Yes, I Rotarian Ritika Gupta, please.
Thank you, Dr. Mohit Sharma. That was a brilliant presentation. And to be honest, it was very, very raw for a non-medical person to take in so much blood. But we really just got a lot of insight into how intricate the surgery is and how nerve matching plays a very big role. Firstly, I wanted to just ask you, how long is that surgery that you do? And secondly, also, like, there was a question about why legs are not happening for leg amputations. And is face reconstructive surgery also similar? And do you also work in that domain as well? Or is there like a different field for that?
So a lot of questions. Generally, it takes around 15 to 20 hours for bilateral upper limb transplantation because of 4 teams and it's unpredictable timing and a lot of things are there. It becomes very complex. So generally, we take around 15 to 20 hours to finish this procedure. Then the second thing is leg transplantation, because the lower limb prostheses are so good. People are running in Olympics with the lower limb prosthesis. So when the outcome is so good and very good hydraulic joints and everything, there is no point, because leg has very much high volume and it is extremely risky to do it on a person. It takes it is incredibly more complex because of the volume of tissue suddenly which comes from somebody else's body, and the body hemodynamics changes totally. So it is not a right thing to do. The worldwide people feel like that, and that's why they have not attempted anything. And then your third question, I missed third one.
About the face reconstruction.
Yeah, face transplantation also we are ready. If there is a patient with totally damaged and deformed face, we can do face transplantation also. We have a permission for face transplantation. We are waiting for the right candidate. We can take the whole face from somebody and put it on somebody else. And worldwide, around more than 50 face transplants have already been done.
I think in India also some face transplant has taken place. In global, Mumbai, no. Okay.
No.
So when you say the whole face, do you mean neck up or you mean face front face, frontal area?
And see, the face, skin and face muscles and everything, nose, lips, eyelids, everything is with the ears or without ears, whatever is the requirement, with the scalp or without a scalp,
Okay.
it can be taken off based on the blood supply and then attached to somebody else who has totally deformed face, which is beyond the scope of reconstruction.
Okay.
Thank you very much.
Thank you very much, Rotarian Ritika Gupta. I think questions people have asked, although there are many more questions, but the time is not permitting. So over to you, Rotarian Ruby Agrawal.
Thank you, Joseph. Thank you, Dr. Mohit Sharma, for such an enlightening and extremely informative session, wherein we could all were able to learn about this transplantation procedure of hand. And I think as an awareness that we do of organ donation, we will be able to add a lot of knowledge by this session. Thank you so much. Thank you.
Meeting is hereby